volunteer coordinator. I just want to welcome you guys to this training opportunity. So excited to see you guys on this call. It just warms my heart every time I see volunteers are willing to take time out of their busy day to learn or train or participate in a response. And it's my great pleasure tonight to welcome our presenters. We've got Dr. Brooke Rossheim and Precious Aguirre, who will be presenting to us information on monkeypox. So with that, I'll turn it over. Brooke, are you going first, or Precious, are you going first?
I'll be going first.
Okay, all right, Precious, you're up. Thank you.
Good evening, everyone. Thank you for joining. You can click to the next slide. So today I'll be giving you the overview of monkeypox and its epidemiology, and then Dr. Rossheim will take over the clinical features, vaccination, and treatment strategies, and then I'll jump back on to go over infection control, collaboration with public health, and risk communication, and then we'll have more time for questions at the end. Next slide, please. So I'll begin with the general overview of monkeypox and the worldwide situation going on right now. So this map shows the extent of the outbreak, and as of September 7th, 2022, there are 56,026 cases that have been confirmed for monkeypox or orthopox viruses in a total of 102 countries. There have been a total of 17 deaths reported, and the World Health Organization reports as of August 25th that cases in Europe appear to be slowing down, but cases in the Americas appear to be increasing. Majority of cases have not been reported to have endemic travels to other countries, and many, but not all of these cases have occurred in gay, bisexual, or other men who have sex with men. Next slide, please. So monkeypox is endemic to certain countries, and here is a list of them. Specifically, West and Central African countries such as the Democratic Republic of the Congo and Nigeria are most populated for monkeypox. This map on this slide shows the countries affected by monkeypox over time. Each one is 1 decade apart, beginning from 1970 all the way to 2017. Next slide, please. So the monkeypox virus, we're still uncertain as to the animal reservoir of which the virus comes from. Monkeypox was first discovered in 1958 when 2 outbreaks of a pox-like disease occurred in colonies of monkeys that were kept for research. Despite the name being monkeypox, the source of the disease still remains unknown. However, African rodents and non-human primates such as monkeys might harbor the virus and infect people. So historically, monkeypox has been rare, the first case being in the Democratic Republic of the Congo, DRC, in 1970, and although sporadic, it has been seen throughout Central and Western African countries. Next slide, please. As of September 7, 2022, a total of 21,274 monkeypox cases have been reported in the U.S., including 389 cases in Virginia alone. Texas has the first reported death in a patient with monkeypox on August 30th, but it is unknown if monkeypox was the cause of death. This patient was also noted to be severely immunocompromised. Next slide, please. So VDH, or Virginia Department of Health, launched a data dashboard on August 22nd of 2022 that summarizes case data in Virginia. As of September 7th, there have been 389 confirmed cases, 16 hospitalizations, and 0 deaths in Virginia. Majority of cases have been male, predominantly middle-age groups. Majority of cases have reported their race or ethnicity as Black, followed by white and Latino. Next slide. So this is an epidemic curve. It's a visual display of the onset of illness among cases associated with an outbreak, for example, monkeypox. So this data is as of September 7th, yesterday. We're continuing to see an increase in reported monkeypox cases in Virginia. And although the data is incomplete in the most recent days, which is why this right portion right here of the curve is gray, you might notice that there is still a decrease going on currently. So that is some good news. Next slide. So in Virginia, as of now, VDH is taking action to investigate suspected cases and facilitate testing at public health labs, DCLS, though most of these lab specimens are not being tested at this facility. Suspected cases should be reported immediately to your local health department. Contacts are identified and monitored based on their level of exposure to a monkeypox case or patient, as well as close contacts and case patients in other states or other jurisdictions. Next slide, please. So now on to the risk. For most people, the risk is low. The highest is among MSMs, which is men who have sex with men. So the outbreak has been declared a public health emergency of international concern by WHO, or the World Health Organization, and it's been declared a public health emergency by the United States Health and Human Services Secretary, Becerra. This outbreak is rapidly evolving and the situation is changing constantly. Healthcare providers should be alert for patients with signs and symptoms of monkeypox. Symptoms can sometimes appear like sexually transmitted infections or STIs, and some patients have also experienced co-infection of both monkeypox and a sexually transmitted infection. Next slide, please. Dr. Rossheim will be taking over from here.
Okay, thank you. First of all, can everyone hear me okay?
Yes, we can hear you loud and clear.
Okay. Just as an FYI, if things start to get choppy, please let me know and I can turn off the video. Sometimes I've had that happen. So
Hey, Brooke,
I want to talk about the clinic.
You're choppy now,
Yes.
sorry. Like right after I said loud and clear, you started becoming choppy. So.
Okay, well, let me go with the video for now, and if it continues to be choppy, is it still choppy?
The last 2 or 3 sentences came in clear.
Okay, well, if I'm coming across choppy, please just let me know and I will turn off the video because I know the internet does strange things. I want to talk about clinical features and data about monkeypox and also VDH's treatment and vaccination strategies. Next slide, please. So first, talk about a little bit of virology. So monkeypox is in the orthopox genus of viruses. And this genus includes the variola virus, which causes smallpox, the vaccinia virus, which causes disease. Vaccinia virus is actually used as a vaccine, cowpox virus, and monkeypox. Yes.
You are choppy. You are choppy. There's every word now.
Okay, let me stop the video and see if, does that do anything better?
So far it is. That's good.
Okay, all right, great. Okay, so we were talking about the orthopox virus genus, which contains variola virus, which is smallpox, vaccinia virus, which causes vaccinia disease, and actually vaccinia virus is used as a smallpox vaccine, the cowpox virus, and also monkeypox. The monkeypox virus is found in what are called clades. So these clades are different types of monkeypox virus. These were renamed by the World Health Organization, WHO, in August of 2022. Clade 2 is formerly known as the West Africa clade, and clade 2 actually has 2 subclades, 2A and 2B, and 2B is largely circulating in the current monkeypox outbreak. Clade 1 is formerly known as the Central Africa clade, and it tends to cause more severe disease. Could I have the next slide? So let's talk about monkeypox transmission. So monkeypox is mainly transmitted by direct contact with monkeypox lesions. It can also be transmitted by body fluids. So for instance, if those lesions weep, then that fluid is considered infectious. It can also be transmitted by contaminated materials. So for example, if someone has a monkeypox lesion or lesions, and those lesions come into contact with bedding, towels, clothes, things like that, then those items can become basically contaminated and can transmit monkeypox. The other thing is that monkeypox is capable of being transmitted by large respiratory droplets, but I will say that it's really not entirely clear of sort of how much that is a mode of transmission of monkeypox, and we'll get to that in just a second. You know, one of the things with monkeypox is that right now, monkeypox is mainly being seen in the current outbreak among a specific population, that is men who have sex with men. But this is not the only group of people that can get monkeypox. Monkeypox can happen to anyone because anyone can have close contact with someone else who has monkeypox, and that can be a way that it spreads to another person. So this is not just an illness among people who are in that MSM category. If you look at the incubation period of monkeypox, so that is defined as the time from when you get exposed to the illness to the time when you start developing symptoms. It runs about 3 to 17 days. The infectious period, so how long with monkeypox is someone contagious? Basically, it's considered from the time the person has symptom onset till the skin lesions have completely scabbed over and those scabs have fallen off. So once all those scabs fall off, you can say that that person is non-infectious. But look at the things that are being researched right now. So active areas of research are, can the virus spread when someone has no symptoms? That's a good question. How often is monkeypox spread through respiratory secretions? Or is there a certain time when respiratory secretions are going to be more prominent in terms of spreading monkeypox? What is the extent of spread through contaminated objects such as clothes, bedding, towels? And the other thing is, what about other body fluids? What about things like semen, vaginal fluids, urine, feces? Can these, effectively spread monkeypox? And these are all questions that are out there. Next slide, please. So talking about VDH's response, VDH helps coordinate testing of potential cases. May be tested by private providers, and so VDH's role in this may not be quite as great. Cases obviously need to be isolated and then evaluated further for treatment. VDH helps identify and monitor the contacts of cases. So one of the things regarding a contact is we want to evaluate their exposure risk. What kind of exposure did they have? Monitoring their symptoms for 21 days, and also coordinating post-exposure prophylaxis. We refer to post-exposure prophylaxis by short as PEP when needed. VDH has done a lot of clinician outreach in terms of clinician letters, webinars, websites, and social media. Also, VDH has done outreach to the public in terms of a lot of media interviews. Some of our web pages are really dedicated to a general public audience, also social media posts, and sharing information with targeted audiences, such as clinicians, also people who may be at risk. This is obviously a nationwide outbreak. And so 2 groups that we need to coordinate with are the laboratory, because labs do the testing to confirm monkeypox, and also with federal partners because all the states are in this together. This is a nationwide outbreak. And then last thing is we want to make sure that we have a good surveillance strategy so that we are actively identifying cases, so that way we know how is this outbreak going. Next slide, please. As far as the clinical features of monkeypox, typically people have a viral prodrome, and this is not unusual for really any kind of a virus. So this could be fever, chills, headache, back pain, really any other kind of pain, fatigue, lymphadenopathy, which is just enlarged lymph nodes. The rash generally occurs about 1 to 3 days after this prodrome. And one of the things that we are seeing is people having lesions in the mouth. So they're having oral lesions. And one of the interesting things about monkeypox is that if you look at the skin lesions, classically, they progress through a pretty orderly fashion. So the rash starts out as what is called a macule. A macule is just a flat rash. So if you were to run your hand over the person's skin, you would not feel anything. The next stage is a papule. A papule is just a bump. So it looks like lots of other bumps that represent lots of other kinds of potential illnesses. The next stage would be a vesicle. A vesicle is just simply a fluid-filled blister. Usually it's filled with serous fluid, which is basically just clear. And that vesicle may turn into a pustule where it has pus in it. And then what happens is it will scab over. So that pustule may sort of resorb on its own, or that pustule may break, and then that wound will scab over. Typical monkeypox lasts about 2 to 4 weeks, and it's basically a self-limited illness that goes away on its own. The only thing about it is that this is not really a pleasant illness. These lesions can be quite painful. They can be itchy. And the thing is that, where these lesions are can really cause some real discomfort to the patient, particularly, in places like the mouth and other places. We have noted presentations of monkeypox in some cases where you've had, instead of a generalized rash, you've had a more localized rash where the rash has been in the mouth, in the genital area or the perianal area, and along with painful swollen lymph nodes. And this is where really, the illness becomes pretty uncomfortable. You can imagine if you've got genital lesions or perianal lesions that are, painful or ulcerating or weeping. This is going to be pretty uncomfortable. Sometimes cases do not have a prodrome. Sometimes the lesions can be in areas where they're in different stages. So the lesions are not following that same sort of progression of stages. And, as far as differential diagnosis, so what other illnesses might we think about? Well, certainly we would think about syphilis, so secondary syphilis, chancroid, which is another illness that can look similar. Herpes lesions can look very similar in terms of pustules that are in the genital area. Chickenpox is another thing that can look similar. Shingles, varicella zoster can also look like this. So a lot of other things can really look like a monkeypox lesion, and it's really easy to get fooled. Next slide, please. So if you look at the rash, and you can see the pictures there, the rash is typically described as a well circumscribed, and what you see is a very circular looking rash. You don't see a lot of jagged edges, a deep-seated lesion. And what happens is you'll in really the top couple of pictures, you see it's a little pustule. So it looks like a little pimple. And really that could be confused with a lot of other things that are not monkeypox. Like we've talked about before, these lesions can occur in the genital area, the anorectal area, the mouth. And sometimes the rash may just simply be a few lesions. It doesn't have to be a whole crop of lesions. Next slide, please. So as far as evaluating the patient, the first thing we want to get is the history. And really what we're interested in first is we want to know some epidemiologic details. So has this patient had close contact with someone with a similar rash, which is really essentially asking the patient, sort of asking in another way, have you had contact with someone who might have monkeypox? Or you may just ask the patient, really you should ask the patient directly, have you had contact with a patient who has had either known monkeypox or probable monkeypox. Another question is finding out about sexual history. Has this individual had sexual contact with other individuals in a network where monkeypox is present? Another is, has this person been outside the U.S., travel to a country with confirmed cases of monkeypox? So as you saw, that there are many countries where monkeypox is present, or has this person been to a country where monkeypox is an endemic illness? And then the last one about an animal exposure is on the list, and it is a question that should be asked, but it's probably less likely to be positive in terms of having an animal exposure from a country where monkeypox is endemic. Patients who have monkeypox should be isolated. You want to use standard precautions and transmission-based precautions because this is an illness that can be transmitted direct skin-to-skin contact. One of the most important things is monkeypox is what we refer to in public health as a rapidly reportable illness. So it is one where you want to contact the local health department by the most rapid means possible. And the easiest way to do that is really just to call the health department. And because that is the fastest way to speak to the epidemiologist at the health district, at the health department, let them know that you think you have a case of monkeypox, so that way the health department can go ahead and start doing the things that they need to do for this. Next slide, please. As far as testing goes, at the beginning of this, DCLS, which stands for the Division of Consolidated Laboratory Services, which is the state's public health lab, DCLS was really doing most of the testing in the state. The good part here is that now we've got big commercial labs that are doing testing. So LabCorp, Mayo, Quest, and the testing that is typically done is really a simple swab of the lesion. That is typically what you see labs wanting. One thing just to note is that if you are a medical provider, you do not unroof the lesion. You do not need to, sort of take a vesicle apart and get some of the fluid from it. That is not needed. A swab, it will do just fine. Testing is not free. Out-of-pocket costs do vary. Definitely look at, so whatever lab you use, please look at their ordering instructions because different labs may have different things that they want, as far as how they want the specimen collected, how they want it packaged, that sort of thing. Sometimes the labs, when they get a positive result, will send their specimen on to CDC for additional characterization. That does happen. Sometimes I'm not aware that that's any kind of a mandate. There is public health testing at DCLS, the state's public health lab. It is available at no cost for patients who meet certain criteria. So for example, if a patient is part of a cluster of cases, that may be one where DCLS will test. If a patient cannot afford testing and really the only way to get testing is going to be through DCLS, that is going to be another reason that DCLS may go ahead and test. It does require pre-approval by the local health department. DCLS testing is available at no cost for patients, but you definitely need to contact the local health department to get that set up. One of the things that a practitioner wants to do if they see a patient who they think has monkeypox is you want to at least consider testing for other infections. So things that you might want to for HIV, for example, syphilis. You may want to test for gonorrhea, other things that can look like monkeypox. Because again, you want to consider other illnesses. We've talked about it before. Obviously, please report a suspected case immediately to the local health department. Next slide, please. So as far as the care of patients all patients are going to need supportive care. And supportive care could be over-the-counter pain medicine, or it may be prescription pain medicine. These lesions, I will tell you, are reported sometimes as being quite painful. And I would say that that's going to be probably pain that Tylenol or Advil probably is not going to take care of. Oral antihistamines can be used for skin lesions that are really itchy or pruritic. If people are losing fluid, so if somebody has a fever and they are losing fluid, rehydration is important. If somebody has nausea and vomiting, giving them some either over-the-counter or prescription antiemetics, so anti-nausea medication. And then sitz baths for someone, if someone has lesions in the rectal area, so they have proctitis. Proctitis is just another name for basically rectal irritation, rectal inflammation, or painful lesions in the genital area. A sitz bath can be helpful as far as providing symptomatic relief until those lesions start to heal up some. Next slide. As far as treatment options, we do not have an FDA-approved treatment in the U.S. for monkeypox. What we do have are drugs that are basically investigational drugs that can be obtained for the treatment of monkeypox. So you see 3 drugs in the table below. The first drug is called tecovirimat, and the brand name is TPOXX. TPOXX is a drug that was approved several years ago, about 4 or 5 years ago, for the treatment of smallpox in adults. And so it can be given either by mouth as a capsule. It can also be given as an IV injection, as an infusion. So TPOXX is something that is out there. It is available for use. Another drug that's out there is cidofovir. Cidofovir is actually an older antiviral drug. It was approved back in the mid-1990s. And cidofovir is a drug that people may know because it's used for the treatment of cytomegalovirus retinitis in patients with AIDS. So in patients with AIDS or acquired immunodeficiency syndrome, which is just another way of saying advanced HIV disease, they can get cytomegalovirus of the retina. And this can really cause serious problems. And cidofovir is an antiviral drug that was approved to treat that. And this drug has shown some activity against monkeypox. So this is another drug that is available as an IV infusion. Another product that is available is called Vaccinia Immune Globulin Intravenous. It goes by acronym of VIGIV. This is a drug that is used to treat a vaccinia virus infection. And if you remember from a few slides ago, we talked about the members of the orthopox virus family. And virus is one of these members of the orthopox virus family. So basically the idea is you can use this drug as a way of treating basically a cousin. Monkeypox is just a cousin of vaccinia virus. And so giving a drug for vaccinia virus may be helpful in terms of treating monkeypox. So that's a third drug. Next slide. There is another drug that is under investigation called brincidofovir. This is a drug that is approved for the treatment of smallpox. It is not approved for the treatment of monkeypox, but again, this is an oral medication. It's sort of the same principle that smallpox is a cousin of monkeypox, and so if you can find a drug to treat smallpox, that it may be effective in treating monkeypox. Next slide. So let's talk about TPOXX, this tecovirimat, a little bit more. So when would we consider using TPOXX? So first, if you've got a patient who has severe disease. So if you've got a patient who's got hemorrhagic disease, confluent lesions. So if you see these, some people present with large rashes that may be kind of, blending together, and it may be, they may have rashes over a good part of their skin. you want to think about TPOXX. If people get a more severe viral infection, so they're getting septic from the virus, they're getting encephalitis, a brain infection, or some other condition that needs to be treated in a hospital, really TPOXX it should be a consideration. Also, people who are at high risk of severe disease. So you may have a patient with monkeypox who right now doesn't have severe disease, but what they do have is they have some other condition that is going to increase their risk of possibly progressing to severe disease. So for example, what about an immunocompromised patient? Somebody who takes Humira, somebody who had a organ transplant, somebody who takes steroids on a regular basis for some other medical condition. Those will to an immunocompromised state. Children, particularly children who are younger than 8, pregnant or breastfeeding women, some people who already have skin disease. So, for instance, the skin disease atopic dermatitis, which most people know as eczema, or for people some other kind of skin disease where their skin is shedding essentially. So these are more severe skin diseases. These people, the last thing that you want is another skin disease to be present. And so TPOXX would be a consideration. And then if you have other patients who are developing complications of monkeypox, TPOXX would certainly be considered. Another reason that you might want to consider TPOXX is if you have lesions in sensitive area, the eyes, the mouth, anogenital area, this is going to be very uncomfortable for the patient. I mean, this is going to be painful. This is, and so the thing is, the goal is really to try to heal these lesions up as fast as possible. And so then a TPOXX would be another consideration. Next slide. So I put this slide in just to indicate, VDH's medication strategy. Basically, the short version of this slide is that if you are a medical provider, you can request TPOXX, but there is a process to do it. So you have to fill out a form. You have to remember that, you are using, if you are using TPOXX for the treatment of monkeypox, that is not an FDA approved use. That is an investigational use. And so there are forms to be filled out, basically using it for an investigational purpose. And so obviously people are going to want to know more about the case. Why is TPOXX being requested? Just to make sure that the drug is being used in an appropriate situation. The good part about this is the TPOXX will be provided at no cost. Next slide. So I want to talk a little bit about vaccination because this is another route in order to prevent monkeypox, and this is obviously a very important route. So monkeypox vaccination right now is not routinely recommended for the general public. It is really intended to be used at this point in time for specific groups that have a higher risk of exposure. And VDH has basically 3 categories of prioritization when it comes to vaccine. So the first priority is traditional, what we refer to as traditional post-exposure prophylaxis. And this is really very simply a contact of a case patient. So if you had contact with a patient who is known to have monkeypox, you had contact with the lesions, then post-exposure prophylaxis would be recommended for you. The second priority is what has been referred to as expanded PEP, or it's been given the name PEP++. I don't exactly know how the name PEP++ became available, but this is what it's been termed. So expanded PEP would be, for example, let's say you are in a group of men who has sex with men, and you don't know whether you've had a monkeypox exposure or not. But what we do know is you are in a higher risk group to develop monkeypox. In that situation, you would fall under the category for getting vaccinated under the category of expanded PEP. So we don't know that an actual monkeypox exposure. We don't know if you are specifically a contact, but you are at higher risk of monkeypox, and so the prudent thing to do is to go ahead and get vaccinated. The third priority is what is referred to as pre-exposure prophylaxis, or what we refer to as PrEP. And PrEP is simply vaccination of people who are at risk of getting monkeypox. And I'll tell you that the best, and this is what we use vaccines for basically every day. And I will give you a good example of somebody that would fall under the PrEP category would be a lab worker. So if you are working in a diagnostic medical lab, so let's say you work at LabCorp, and let's say you are in the DNA lab where specimens come in that might be specimens of monkeypox. They might be specimens of all kinds of other things too. But the thing is, that some of those specimens coming in are going to be monkeypox. That's a person that it would make sense to vaccinate ahead of time, even though they may have nothing to do with any other risk group. So one of the things about vaccination is that if you limit vaccination to just that priority category number 1, traditional PEP, so that's for known fact, you may not really control the outbreak. The reason being is that some cases may have many, many contacts, and either A, we may not find out about all of them, or the doctor may not find out about all of them, and B, it may be very difficult, if not impossible, to locate all of those contacts. So this is why you want to start thinking about expanding that net, if you will, to include not just people that have had a contact, but that's where expanded PEP comes in. So you're broadening that net to include our at risk, and that's what the intent is. So next slide. So we have 2 vaccines that are available for monkeypox prevention. One of them goes by the name of Jynneos. One is ACAM 2000. You may have heard of these vaccines. These vaccines are both available, but the one that is really being used right now in the U.S. is Jynneos. So that's the one that I'm really going to spend more time talking about. Jynneos is actually a vaccine against the vaccinia virus. Okay, now remember, the vaccinia virus is a cousin of the monkeypox virus. And so what has been found has been that if you vaccinate against we are taking advantage of the cross immunity. Because what has been found is that if you vaccinate against the vaccinia virus, it actually provides good immunity against monkeypox. So cross immunity is our friend here. Jynneos is made by a company called Bavarian Nordic, and Jynneos is a 2-dose vaccine. It is FDA approved for the prevention of both monkeypox and smallpox. One of the things about Jynneos, however, and this is something that came out last month, the FDA had a big press conference about this, is that our supply of Jynneos is limited, and then we're going to talk about that a little bit more. So under the approved FDA approved language, Jynneos is given as a subcutaneous vaccine. It is 0.5 ml. So Jynneos comes in a tiny little vial. You drop the whole, 1 vial equals 1 dose. You drop the whole vial. You inject it subcutaneously. The person then comes back 4 weeks later, 28 days, gets a second dose, and then they are done. So that's the Jynneos vaccine. By contrast, and Jynneos, one important thing is Jynneos is a live vaccinia virus but it is not capable of replication in human cells. So people cannot get a vaccinia infection from Jenios. Now we need to talk about ACAM 2000 a little bit. ACAM 2000 is also a live vaccinia virus. The difference with ACAM 2000 is that this is not an attenuated or weakened virus. This is a live virus. This product is capable of causing a vaccinia infection. Now, I want to put this in context. That is not very common. It is actually not common at all. But it is something to be aware of when using ACAM 2000. So some people may know ACAM 2000 because some of us, on this call, like myself, have been, when I was a little kid, I was immunized against smallpox. And so I have the scar over my deltoid to prove it. And I'm sure other people on this call probably have the same thing. So ACAM 2000 is an old product, but it works, and it still works. The way that you give ACAM 2000 is you use what is called a bifurcated needle. It's like a little pitchfork, essentially. You dip the pitchfork into the solution, you jab the person's skin over the deltoid 15 times, and then you need to see the person back in the office about 6 to 8 days later to make sure the vaccine is what we call taking, or that it's a good take, that the vaccine is working. ACAM 2000, one of the things I would tell you about ACAM 2000 is in the Strategic National Stockpile, we have enough ACAM 2000 right now to vaccinate every man, woman, and child in the entire United States. There are well over 300 million doses of ACAM 2000. The only problem is that, ACAM 2000, to have to go through this whole thing, as opposed to just giving a couple of shots with Jenios, to have to go through, first of all, using the product that is a live vaccine. That's one thing. So you have to be careful with the product itself, and then having to come back for a visit. There's a lot more to this product than just Jenios, where you don't have to do all these things. So Jenios is really the preferred product at this point. Next slide. So the next slide talks about some of the risks of using Jenios and ACAM 2000. I have touched on some of these already. Jenios is a new one. Jenios is frankly a safer vaccine for a vaccinator to use, because you don't have to worry about the fact that that you may have developed a vaccinal infection, which again, I want to put in context, that is not common. The other thing with Jenios is really there are very few contraindications to using Jenios. With ACAM 2000, you have to use really strict infection control measures. You want to make sure that you don't auto-inoculate yourself, that the vaccinator doesn't inadvertently, inoculate themselves, which can happen. Also ACAM 2000 has been associated with some heart problems, myocarditis, pericarditis. Again, not common. I want to put it in context, but those things have been reported. And like you see on the slide, there are a number of contraindications to using ACAM 2000 that you have to really be careful of. And so as you see at the bottom in the red box, Jenios is the primary vaccine being used in Virginia, and really going one step further, Jenios is really the primary vaccine being used in the US. Next slide. So remember we talked about the fact that there is not enough Jenios, and FDA, had a press conference with CDC and the White House, and so what happened is in early August, FDA came up with a new strategy for using Jenios. And what has been noted is that there is immune tissue in people's skin, okay? And so one of the things that had been noted with Jenios is that you can give Jenios intradermally. as an injection into the skin instead of giving it as a subcutaneous injection. And when you give Jenios as an intradermal injection into the skin, really where you're trying to go is right below the epidermis, right below that top layer of skin. So you're really trying to get it right into the dermis, which is the second layer of the skin. Well, first of all, you can use a lot less product. You can only, all you need one of Genio given intradermally instead of the 0.5 ml that is given as a subcutaneous injection. So if you use Genios in this way, you just increased your vaccine supply by 5-fold, which is tremendous. And so this is what happened in early August. So FDA issued an emergency use authorization so that Genios could be given in this way that is different than its FDA approved use. And so and there is data in the literature that if you give Genios by an intradermal route, what you get is you get sort of roughly similar immunity when you measure antibody levels to what subcutaneous injection. And so people took that and they said, okay, well, since we don't have enough Genios to give all subcutaneous injections, let's go ahead and do. And so that's what we do right now. So for adults who are being immunized against monkeypox, we are using intradermal Genios rather than subcutaneous Genios. Now, for children who need Genios, they need to be given subcutaneous Genios because basically we just do not have any data on kids when it comes to this intradermal route. I just saw a note in the chat, yes, giving an intradermal injection is a skill. And one of the things that we've done at VDH is we've gone around the state to show people how to do intradermal injections. Now, fortunately, we give a lot of tuberculin skin tests. And how is a tuberculin skin test given? It's given intradermally, exactly like you would give somebody an injection of Genios. So we have a lot of nurses who are actually very familiar with giving intradermal injections, but you're right, it is a skill. It's a learned skill, and it is tricky because sometimes you can go too shallow, sometimes you can go too deep. But for adults, this is our primary method, and what it does is it allows you to stretch that amount of vaccine much farther. Next slide. So again, I'm not going to spend a long time with this slide because we've talked about this a little before. So post-exposure type is vaccination of an individual following exposure to a known case. Now, one point that is worth noting is we want to vaccinate that person early. So ideally, we want to get the vaccine in them within 4 days of exposure. Now, that is moving fast. So that's the goal, is to get it in them as soon as possible. Because if we get it in that fast, we may prevent that person from developing monkeypox. Expanded post-exposure prophylaxis, we've talked about that. That's if you're part of a risk group, even if you have not had a documented exposure, we are going to make that net wider so that we are going to capture more people, even if you've not had a known exposure, but you are at risk. And then pre-exposure prophylaxis is vaccination of those at higher risk for monkeypox. And the classic example that I like to use is the lab worker who's working in the DNA lab at LabCorp or Quest. Next slide, please. So a little bit about accessing vaccines. I will just say the U.S. government has already reached out to Bavarian Nordic to try to get them to make more Genios. That has already happened. The majority of the vaccines are going to state health departments, and some community providers are also getting vaccines. If providers want vaccines, they really need to reach out to their local health department. because this is where most vaccines are, this is where Jynneos is really going to be found. Next slide. One thing that is very important to note is health equity. We know from COVID that we have a lot of work to do in this area. And with the monkeypox outbreak, what we have seen is that it disproportionately affects people who are gay, bisexual, men who have sex with men, and also people of color. And the thing is, it is incumbent upon us in the public health world and also the medical community at large to make sure that we get both knowledge about the fact that monkeypox is out there, knowledge about the fact that treatment is out there, that we have TPOXX, that we have vaccines, and so that people know that these things are out there. And then it's also incumbent upon us to get these products to where they need to go. So not just the knowledge, but also about particularly people who are racial or ethnic minorities. We want to make sure that they have access and ready access to these products so that they don't get monkeypox unnecessarily. They can get vaccinated in a timely way, treated in a timely way. Next slide. Okay, I'm going to turn it back over to Precious, who's going to keep going.
So I see in the chat we're having some audio issues. Can everybody hear me okay? I'm not sure if, Engineer, can you let me know if...
Yeah.
Okay, perfect. Alrighty, great. Love to see all the thumbs up. Thank you, guys. So I'll go ahead and explain the infection control, collaboration with public health, and risk communication. Next slide, please. So infection prevention and control, it's important for patients with possible monkeypox to be in isolation with standard and transmission-based precautions. So masking patients, covering lesions during movement or transport if they have to get up or leave the room. Limiting patient movement is necessary, is important unless it's necessary for medical care. Patients should wear a mask and cover their lesions and utilize standard PPE. Now this goes for healthcare workers and anybody who comes into contact with the patient. So gowns, gloves, N95 respirators, and eye protection can help slow the spread. Staff should also avoid activities that could spread lesion materials, such as shaking laundry. We'll go more into proper removal of these items in the next few slides. But soiled laundry should be gently and promptly contained. Prevention during current outbreak. So to prevent spread of monkeypox, we recommend avoiding sustained skin-to-skin contact with people who have a rash that looks like monkeypox. For example, you don't want to cuddle, have sex, kiss, or hug someone with monkeypox. Don't touch the rash or scabs of a person with monkeypox, whether this is suspected or confirmed. Consider the risk of attending gatherings where there will be close, sustained skin-to-skin contact, and consider limiting your number of sexual partners. Having multiple or anonymous sex partners may increase your chances of getting monkeypox, and limiting the number of sexual partners that you have may reduce exposure. Hand hygiene and vaccinations are also important prevention tools, and vaccines for pre-exposure and post-exposure prophylaxis are available, as Dr. Rosheim just explained. Next slide. Thank you. So this is a recent study from CDC's Morbidity and Mortality Weekly Report, also known as an MMWR. So these are results of an online survey conducted in August of 2022, and 48% of men who have sex with men reported reducing their number of sexual partners. 50% of men who have sex with men reported reducing one-time sexual encounters. And 50% of men who have sex with men reported reducing sex with partners met on dating apps or at sex venues. So these findings suggest that men who have sex with men are taking actions to reduce the risk to themselves and to their partners. So this is important, seeing as though this is the primary population that monkeypox is common in. Next slide, please. Notifying your local health department. Providers must report a patient with either suspected or confirmed monkeypox infection to their local health department. It's preferred by phone because it's a more of an immediate response. This website here has a locator tool that can help you find your nearest health department wherever you're located. I see a lot of different areas for MRCs, so these slides should be available, and the links to this website will be available after time, so you can go ahead and save that for future reference. Next slide, please. So the public health response to controlling outbreak, these are some of the steps that VDH specifically is taking. As stated earlier in this presentation, VDH, or the Virginia Department of Health, investigates all reported or suspected cases and facilitates laboratory testing. And that's how we're able to identify surveillance, identify cases early, and conduct laboratory investigations. VDH also asks healthcare providers to immediately report suspected cases to local health departments, even if these tests are being conducted at a different commercial laboratory. And that's how we're able to implement infection control measures and isolate these cases. So when cases are detected, VDH identifies close contacts and monitors them based on a level of exposure. And VDH monitors Virginia residents who have been in close contact with cases or patients in other states or jurisdictions. And that's how we're able to conduct contact tracing and monitor contacts, provide guidance and education, and conduct outreach to social networks of men who have sex with men, their contacts, to the public, and to all other healthcare providers. So we're trying to do a lot with public health response right now, especially why trying to get out this information is so important. Next slide, please. So VDH is vaccine administered dashboard is a dashboard that was launched on August 22nd, 2022. This data is as of September 7th, 2022, 8,107 first doses and 1,558 second doses have been administered. The majority of the vaccines that have been administered to males, middle-aged persons ages 20 to 29, and ages 30 to 39, and for most who have reported their race or ethnicity as white. So this little graph here just shows different areas of Virginia that showed the amount of vaccinations in each area. Now this website is also available if you're interested to see more vaccination information about the people and the areas that have been vaccinated. Next slide, please. So let's talk a little bit more about risk. It is important to emphasize that anyone can get or spread monkeypox. Although there are specific populations like gay, bisexual, or men who have sex with men that are more at risk, most cases to date have been in this population, but it's crucial to minimize that stigma against the men who have sex with men community because disease epidemiology can change over time, meaning that the public and other public health providers should be aware of all of these symptoms and behaviors that can lead to the spread of monkeypox. Now, certain behaviors, such as attending groups, events, or being in a large populated area where skin-to-skin contact is either common or sexual contact is known to be common. These are areas that you can kind of minimize the risk by understanding for yourself that maybe these things should be avoided. So you can also combat the stigma by providing fact-based information and emphasizing that monkeypox is a public health concern for everyone. Hopefully the information shared in this presentation today is something that you can continue to share with people that you may know. Next slide, please. So these are the take-home messages. In general, the risk of infection for most people is low. In the current outbreak, most people with monkeypox have reported close, sustained skin-to-skin contact, including sexual contact with other people. Keep monkeypox in mind when you're evaluating patients, especially if they have the characteristic rash. Keep in touch with the local health department and report suspected cases. And stay up to date on information from the Virginia Department of Health and the CDC. Next slide, please.